Looks like we've got a lot of people. I think a lot of people are kind of bored sitting at their own houses. I guess one thing that we could do quickly as people are joining, I know that some people are fairly new to attend these rounds. And so we hope that as time goes on, that these can be a source of materials, especially the ones that we've recorded, so that we can go through and use some of the information as teaching material, but also the main goal of this is from a clinical standpoint for us to show and discuss once we've looked at the pathology, the best treatment, maybe prognosis, and kind of have two good cases that we can discuss the best way to manage some of these patients that are having biopsies. Hopefully you all can hear me. If so, if you don't want to say something, you can add it to the chat.
Yep, can hear you.
Hi, Laura.
Hi.
Good to see your name on here.
But see, here's why you don't see my face. Because I look like a trash person.
Okay.
And there's a cat in the background.
You realize this is a lot of clinicians we've never met before.
Hi, clinicians.
Okay.
Okay, I'll go away now.
That's my colleague, Dr. Hogan. Oh, good. Dr. Syme is on. Harriet, you typed your name with one extra R, I think. Unless you do spell your name with 3 R's. We'll see. I guess another quick thing is I will say that there are some pathologists in this group. So for example, hi, Dr. Syme, I can see your face. It's good. For example, Dr. Martinez is one of our lecturers here at OSU, and she's recently been boarded, and she and I have worked on a couple of kidney projects together. Dr. Wong is at Purdue in her 3rd year of residency. Mary, is that Mary Nabity? I think that might be Mary Nabity.
Yes.
Yay, good, okay. So there will be pathologists every so often. If I want to ask, do a pathology quiz question, I might specifically ask the pathologists for their differentials, again, to make sure that not only the clinicians, but the pathologists are also learning and being involved in this. But I'll try to be specific when I have a question. And then lastly, I have to say that I did own a headset, but then when I got a new laptop, my little headset microphone doesn't work anymore. So I use my computer audio, which means that every so often you might hear my dog in the background, and I apologize in advance. And Dr. Syme and Dr. Maloney, I feel also quite bad, Dee, because whenever you guys have submitted cases, I can never tell if you have an R for your name. So I might have misspelled your name on a couple of our reports, and I apologize for that. But if I'm not in my office, all I have is the report that we've given to you, but we can go through the pathology based on images from that, as opposed to driving a microscope. But if you want to just start to discuss, I'm not sure if you might have information that you need to share on your screen, or if you just want to chat about how this case presented.
Yeah, cool. Can you hear me okay? Great, thanks. No, my name is always spelled fine, don't worry about it. Grant, so Vera was, at the time of presentation, a 3-year-old female neuter crossbreed. Her age was a little bit unknown because she had been rescued about a year prior to this from Ireland. And she had presented to us with a kind of a 5 to 6 week history of PUPD and weight loss, and then abdominal distension. And at the local vets, they had documented abdominal effusion and also hypoalbuminemia at 20 grams per litre. And then here we had documented further hypoalbuminemia actually at 9.3, and also her cholesterol was elevated at 6.9. And so we had also done a urinalysis at this point. Sorry, I'm trying to find the information. And her USG was 1020 and her UPC was 19.9. So at that point, we went to do a renal abdominal ultrasound, and she had some free fluid in the abdomen, and both kidneys show relatively poor corticomedullary definition but a smooth outline, and there was no renal pelvis dilation, and both kidneys were 5.3 centimeters in length. So we did the renal biopsy then at that point.
Unmuting. Okay, so hopefully now you guys can see just the kind of the copy of our report and the information that we have. Correct?
Yeah, perfect. Thank you.
I already see the diagnosis because I have it there, but the renal biopsy was, let me just see how many glomeruli we got. While we have a whole bunch of clinicians here, I like to do a little bit of a blurb about the quality of renal biopsies and what is often considered sufficient for a diagnosis. Dr. Lees often says that depending on the disease, we could make a diagnosis on a single glomerulus. And so there's not always an easy answer to say that if you have one, if you have 5 glomeruli, you're going to be able to make the diagnosis. Or if you have 10 or 20, my interactions with my physician nephropathologist, the MD nephropathologists, they usually want 10 glomeruli to look at, but they are happy if they get more than that. And they feel a lot more comfortable when they have 20 glomeruli to look at. So that's the kind of goal that we're shooting for when we're looking for a sample. So this one was quite good. It had about 30 glomeruli. And then hopefully you guys can start to see the photos, which I'm going to make a little bit bigger on my screen. So the glomeruli themselves had this kind of eosinophilic material that expanded the mesangial zones. I hope you guys can see the little crosshairs. Is that correct?
Yeah.
Okay, so we have this kind of eosinophilic material. It expands the mesangium. Sometimes it actually kind of goes and impinges onto the capillary wall as well. And so because the material, this type of material is pretty spot on for what the diagnosis is going to be, which is amyloidosis. The special stains, and again, a little blurb about how we do this processing at Ohio State is that we get the slide with the H&E slide, and usually the PAS stain comes out about either that same day or the next day. And then the other stains are usually a little bit later, but I don't always choose for the lab to run the Congo red, which is the diagnostic stain for amyloidosis, because it's an extra $25. And if it's something where it's, immune complex disease, I don't need a negative Congo red to show me that. So the Congo red is just kind of set to the side, and I don't actually request it until I see this type of eosinophilic material within the mesangium. The PAS is actually pretty good as well to help me figure out what the diagnosis is. It's this kind of pale pink material, whereas, let's see, Bowman's capsule basement membrane can be quite like fuchsia colored, maybe is the right term for that. Here would be a protein cast, and see how densely pink that is. Whereas the material within this mesangium is quite pale, pale pink. And then you can kind of clearly actually see the glomerular basement membrane of the capillary walls as I track along that way. And that would all be the capillary wall. And then in the middle would be the capillary lumen. So this material is going to start to come in and encroach upon that lumen. And so you might get scenarios where now you have a very narrowed capillary lumen, and it's going to be very hard for red cells to circulate through there. So the PAS is also quite diagnostic. And my MD colleagues often like to say that this material kind of looks waxy. It looks like candle wax is kind of dripped onto that glomerulus. And I often mention this, so I know I'm repeating the same stories, but we have new attendees here. The use of the term waxy to describe amyloid actually has ties way back to when you did autopsies prior to any kind of microscopy, and you were just dissecting bodies for like medical school in Italy, and they would be full of like livers that had hepatic amyloidosis, and you could literally just punch your finger through that liver because it felt like candle wax, because it was that amyloid was so it changed the actual architecture of the hepatic cords, and it basically compressed the hepatic cords, and it was just this extracellular matrix. So they often, even back then, even before you had microscopy, would say that amyloid had a waxy consistency, and that's part of the reason we have this holdover by saying it's waxy on histology. A little history lesson there. So the trichrome stain is going to be very helpful as well. Again, the mesangium is expanded. It's kind of this pale blue to sometimes peach. It's very mottled for the trichrome. And again, it's going to compress the capillaries. So the one additional thing about this case is that about amyloidosis is that you could have other things that expand the mesangium and compress the capillary loops. So it doesn't necessarily just need to be amyloid fibrils. If you had sclerosis, so deposition of collagen material, it also could expand the mesangium and it could compress capillary loops. But sclerosis is going to look very different. Sclerosis is very collagen. So it will be dark blue, and the PAS could be anywhere from dark pink to a bright pink. But whereas amyloid is going to be this like very pale color. So I can usually tell the difference between sclerosis and amyloidosis fairly easily just by using these stains. Here's a glomerulus that's completely effaced. Not completely effaced, sorry. Large portions of this glomerulus are completely effaced. So if you look at this particular segment of the tuft, really honestly, you have this tiny, tiny, tiny capillary lumen. And so any red cells that are trying to circulate through there are going to be very compressed and distorted. And then here would be an example of not just being in the mesangium, but also extending into the capillary wall. I'm not sure at this region why we don't have the silver stain, other than maybe it was a day we weren't doing silver stains very well. So the silver stain may not be here. But for the pathologists that are paying attention, what would we expect? I'm going to pull up the chat if I can. What would we expect the silver stain to look like if we had the silver stain and it was working effectively that day? If any pathologist wants to speak up, you can, or you can put it in the chat. There's a very specific thing that the silver stain does with amyloid. Any pathologists? Maggie? Let's see. Okay, so Maggie chats up here that yes, it should be, it really honestly, so the amyloid fibrils don't bind to the silver of the Jones stain. So when I say the silver stain, that's the Jones or the JMS. And so it has a silver component, and the silver doesn't bind to the amyloid fibrils. So there would be a lot of pallor in the middle. And actually, I'll be able to show you an example of that, because that's going to be our second case scenario. So sclerosis and collagen that is involved with sclerosis does bind very closely to the silver material. So it would be very dark black if it was sclerosis, whereas the fact that amyloid won't bind to the silver particles, it kind of gets this hazy gray picture. And then the diagnostic stain, as we've said, is the Congo red. And here is a bright peach staining for the Congo red. So we are verifying that this material is amyloid. The Congo red, as the clinicians, I think the pathologists know this, but the Congo red should be a thicker slide. So if you were to work up an amyloid case in a regular histology lab, you might need to remind them that they need to cut this at a much thicker section than what they would do for a regular kidney section. So our regular kidney sections are 3 micron. Some labs cut them at 2 micron thickness, whereas a Conga needs to be about 8 to 10 micron thickness. And that really helps us with amyloid cases that might have very minimal amyloid. And so maybe they only have a small amount of amyloid. If you cut it at a thicker section, you're more likely to catch some of those amyloid fibrils, and then you would be able to see them on the Conga. This particular case has a good amount of amyloid, so it's not going to be an issue, but they should standardly cut their Conga sections at 8 to 10 micron. Okay, so based on that, let's see what else I said about this case. Any questions so far? I'm going to look at the chat to see if there's any questions. If I can do that, let's see. Any chat questions? Chat. Okay, no questions so far. And I will say that even though we talk about, I said the JMS stain, the Jones stain, that silver stain that I mentioned was actually overstained, so it was very difficult to interpret it, which is why I didn't take any photos. I apologize. Well, I'm just sometimes the lab doesn't come out right. But so the apple green birefringence, when viewed with polarized light, so it has this kind of like pale green coloration. It is fairly difficult to photograph to put in reports. We have a couple of examples of really great apple green birefringence in our textbook that we wrote. It can be photographed, but sometimes it's difficult. There actually is a lot of problems with like background light. So my microscope and my camera sits right against an opposite a window. So if it's a sunny day, it's very difficult to take a lot of photos because the sun will seep in through the oculars. And then it changes the refringence of the light that goes to the camera. So it's very annoying. But it's one of those things where I can see it with my own 2 eyes. It's just difficult to photograph. So I do like to give you guys a little thing, like when I've said that it demonstrates apple green birefringence, I've looked at it. It's just very difficult for me to photograph. And then when we were in kind of writing our chapter on amyloidosis in our textbook, we kind of were unsure how to say, degrade severity. I think Dr. Kathy Brown had comments, and I think we really liked it and how we used it maybe for the WSAVA study, is that mild is when it's present in the mesangium, but really the capillary lumens don't seem to be affected or effaced. Moderate would be when some of the glomeruli, when some of the capillary loops get compressed or effaced. But there are other portions of the glomerular top that still have open capillary loops, whereas severe would be more like that middle glomerulus I showed you, where it's just largely effaced by the amyloid fibrils. And there's very, very few open capillary loops. So that would be a severe glomerulus. And to be honest, oftentimes when we get biopsies, there is a range. It's not like every single glomerulus is moderate or every single glomerulus is mild. So oftentimes we'll have some that seem to be moderately affected and others that seem to be severely affected. And then particularly in this case, we did have some interstitial nephritis. So we had some inflammation around the tubules. That's kind of just the chronic non-specific interstitial inflammation that we're gonna see in many cases. For those of you who have submitted biopsies to us and that have had a diagnosis of amyloid that has been made, usually what happens is I can be pretty sure within 24 to 48 hours that it's amyloid. And so I will email the clinician and say, hey, look, it's amyloid. I don't know if you want to pay for everything because it's going to be a fairly, the EM results aren't really going to tell us anything more than verifying it's amyloid. And so I usually offer to stop at that point, and then I charge a lot less for the final diagnosis because the EM is the most expensive part of the analysis. So if there's a way for me to get away from having to do EM, then I try to at least give you guys the chance to cancel the rest of the tests. And that's what happened in this particular case, is that they didn't really need to go forward with amyloidosis, or sorry, with the additional diagnostics for this case. So we get amyloid. I think our WSAVA study showed it was around 18% of our proteinuric dogs. When we looked at more recent analysis, it's still in the 15 to 20% range as far as the causes of dogs that have proteinuria. So it is a diagnosis that we render frequently. I think that what we're interested in now, and what Dr. Mnabidy's veterinary student is working hard to do, and I feel bad because we haven't been able to complete the data set for him, but we are trying to say, well, maybe amyloid actually isn't a death sentence. And I don't know if anybody in the clinical side wants to talk about the current literature that exists to say that amyloid will lead to a very short median survival time. So I would be interested to hear what the clinicians have to say, and then we can specifically talk about this case, because I think this case is still alive, and by the biopsy, it was biopsied over a year ago, and this dog is still alive. I think. So,
oh, sorry, bad news, not anymore.
Oh, bad news.
She got put to sleep in January. But yeah, I think I had painted quite a poor prognosis, and the vet used to send me an email quite frequently to say she was still alive, even though she was still really proteinuric. But her albumin had come up, but yeah, the latest was that she got put to sleep in January.
Okay, so but she lived for 11 months, right?
Yeah, so she did well, better than I thought.
Any of the other clinicians want to talk about what I mean, I would be interested to hear how you give this information to the clients about amyloid.
Yeah, this is Shelley. I feel like the survival of amyloid, it tends to be short, but every once in a while we see these cases that live quite a long time, and I'm not sure how to determine which is which. They don't really seem to respond to any specific treatment that we use.
We had a case that was, so we looked at a human that had amyloidosis, and actually that patient, I mean, it was a light chain amyloid. And so we were kind of trying to discuss based on knowing when the human actually had the B cell clone that was making the light chain, which then was like years ago. I think it was like in 2005 or something. That's when it had the leukemia, or might have been multiple myeloma, whatever bone marrow dyscrasia that was present. And then they ablated the bone marrow and did stem cell transfer. And the patient then was back to was in remission. And then I don't know, up until like that was in 2003 or 2004, and then the patient developed proteinuria in 2020, and then they were diagnosing the light chain amyloidosis in 2020, and it fit with what the clone was originally making. So we had a long discussion about amyloid and how long it takes for those, if you're a human and you have light chain amyloidosis and you get rid of the clone, there are data to say that the amyloid fibrils can dissolve and go away. I don't know how they do that, but there are case reports of, oh, and then the light chain went away, and then now the patient's not proteinuric, and the repeat biopsy showed, less amyloid than previous. But they say it takes years for it completely to dissolve if you've gotten rid of the clone. But I don't know how that would go away, whether it's macrophages coming in or mesangial cells starting to dissolve the fibrils. And again, it's a different beast. It's a different type of amyloid fibril because it's a light chain, as opposed to what we see in dogs is mostly SAA amyloid. Are there any case reports of amyloid resolving in dogs? I'm not aware of any. It sounds like everybody else is not aware of any. So that is, okay. And Dr. Vaden says not that she's aware of either. I've gotten occasionally excited because I've thought, oh my gosh, I'm going to have amyloid and it's a dog that has B-cell lymphoma or something like that. And I'm going to find light chain amyloidosis in this particular case, as opposed to serum amyloid A amyloidosis. And I've never actually been able to diagnose light chain amyloidosis in the glomeruli of dogs. Light chain amyloidosis does happen in pathologists studying for boards. What species do we see light chain amyloid deposition and what organ? As you guys think about that, I know Agnes is studying for her 3rd year in boards, so think about what species and location light chain amyloidosis is documented in. But it sounds like for this particular case, the dog did fairly well, survived for about 11 months. It sounds like the albumin improved, but the dog remained proteinuric during that time. Did the dog eventually become more significantly azotemic for this?
Yeah, I don't have the most recent bloods. I think maybe about 6 months ago, they kind of stopped doing any more investigations. I don't know if they run out of money, but she wasn't azotemic the last time we had checked.
Okay. Are there any other comments or questions? I guess Shelley said there's really nothing we can do to treat them, but is there, I don't know if you guys want to discuss amyloid in general, or
I have Astrid speaking here. I just wanted to ask or discuss because I was wondering if you look at the amount of amyloid that's in this biopsy, and especially then if you know that the dog lived for another 11 months, that how come, because most of the amyloid is deposited in the glomeruli, so how can it be that there's no azotemia developing? Or is it maybe that we don't recognize it because it was a very skinny dog, so even though the albumin went up, that it didn't go to normal, and muscle tissue wasn't that abundant on this dog, or I don't know, I just was wondering about it.
Yeah, I guess when I saw the dog, it was in relatively poor muscle condition. And its creatinine was 101, and our upper end of our reference range would be 144. Sorry, I know your units are different, but yeah, so potentially maybe that might be an explanation that she was in poor body condition.
But didn't it say that her body condition score was 5 out of 9?
I think her,
but
I'm sure I remember her being muscle wasted.
Yeah.
It is written as 3 out of 3. I think it was a transfer. Don't blame me. But yeah, I do remember her being like mild to moderate muscle wastage, and I guess 101. So I don't know.
Or do you guys run SDMAs over there routinely?
Not unless we'd have to send the blood externally to IDEX for that, so we don't have that in the in our university diagnostic lab. So it would depend who the supervisor was whether something got sent, but usually not.
I would say from our perspective at Ohio State, and Dr. Byron is, she was on here earlier, oh, she's there still. You know, we had a medicine resident who presented and did her master's thesis about cachexia in cats with chronic kidney disease. And so we had a long discussion about, you know, body condition score versus muscle condition scoring. And Dr. Parker, who's one of our nutritionists and internists here, you know, kind of helped me figure out that I think we've been teaching our residents and our vet students that when they're on the autopsy floor, we're probably teaching them incorrectly. And so we have a very weird way that we're going to teach our vet students in 2020 for this class of 2021. But I'm hoping with maybe the next time we get students on the autopsy floor, we're going to try to figure out better ways to teach them muscle conditioning. It'll be hard, it's a dead animal, but I do feel like most students don't really understand the value of muscle condition versus body condition. And so if we can get one of those kind of hands-on skills on the post-room floor, it would be helpful for them. Dr. Byron, do you have other comments about muscle conditioning scoring over in clinics?
We don't really use a number. We usually just say mild, moderate, or severe wasting or normal. I think we primarily, just like in the study, we primarily look at the epaxials, palpate the epaxials. Obviously, orthopods use muscle conditioning over specific joints and, you know, the hips and that kind of stuff. But for more systemic, Parker sort of encouraged us to use primarily the epaxial muscles. And that was what this resident did with her study. She looked at a specific CT slice of the epaxials and measured it against the height and some proportions of the relevant vertebrae at that level to sort of make it appropriate for the size of the animal. I think it's really valuable because particularly in like PLE and PLN cases, we do see significant muscle wasting, and yet some of those animals may come in and they're actually fat, so they have a lot of fat on them, but their muscles just waste because they're protein wasting. So you know, even our Yorkies with PLE, sometimes a lot of times they come in cachectic, but certainly in cats, we definitely see cats that are fat but have very poor muscle condition with CKD and with you know, other problems.
Okay, well, if there's, I have a couple of other kind of a little bit gee whiz lesions that I thought in their current cases, and I have to apologize, I don't think I'm gonna have a final diagnosis for them, but they just were quite striking. If you guys would want me to show you some of the images, I actually haven't even written the reports yet because they're this new, they just came through the system. And also, nobody answered my question about what other species gets light chain amyloidosis and what organ system. So I'll share it with you guys. And correct me if I'm wrong, Maggie, because you studied for boards more recently than I have, but isn't light chain amyloidosis one of the types of nasal amyloidosis that horses get? And then she probably will type up and say that I'm incorrect, but let's see. Okay, as I'm looking for this current case, one moment.
Hey, Rachel.
Yep.
I had a case that I got a consult on from a referring veterinarian who had done endoscopic biopsies. It was actually from another internist who'd done some endoscopic biopsies on a dog that had been vomiting blood, like digested blood, and it came back with gastric amyloidosis.
Yep.
Which I guess there's some weird genetic mutations in people that can happen, but there's zero literature on it in animals. And I feel like I've heard of it, but does anybody else have any thoughts about that? I know this is not necessarily a GI group, but I mean, I asked Radinsky and Winston and Parker, who are all very GI centric, and they were all like shoulder shrugs, you know?
I've seen, so I guess my perspective of it is I was at liver rounds in the med school. If I can, I sometimes go to liver rounds. And I guess one thing that I found striking about that, we were looking at a liver biopsy. It turned out the patient did have hepatic amyloidosis, and that's what the biopsy showed. But they said that I guess amyloid in the gut, severe GI pain. And so that was the presenting complaint for this human patient, was just like horrible, like colic signs and just real severe abdominal pain. And then when they went into the clinics, they realized like all their liver values were crazy. And so they did GI biopsies at the same time they did liver biopsies, and it turned out it had amyloid in both locations. And the MDs were just like, yeah, that's what happens. Like amyloid causes really bad GI pain. And I was like, but I don't understand how it would. It's just an extracellular matrix protein. Like, is it around the nerve? Is it causing pain? That would be my experience. We have seen it. We have seen amyloid deposition in the gut of multiple species. It's actually pretty, it's one of the boards things that we tell our residents to study for primates, because they can have a lot of amyloid in their gut. But I don't know if it's something that is well reported / characterized when we think about dogs or cats. Does any other internist have comments on that?
We actually advised the vet, she had the had the samples processed, I think, through Antec. So we actually advised that she request the slides be sent to Texas A&M to the GI lab there, and see if their path crew could take a peek at it, just to verify it, because she didn't have pictures, and she basically only got a diagnosis. She didn't get anything descriptive in her report.
Yeah.
So unfortunately, she didn't know the details of what they saw or which stains they did and that kind of stuff to verify it. So
Do you know what breed it was?
it was some terrier thing, I think.
Okay.
And, that's the thing. I mean, I would think you get abdominal pain from liver fracture, obviously, when they're really severe amyloid, but for the gut, it was very strange. And I don't even think it said specifically what layer of the gut the amyloid was deposited in. Like, was it in the submucosa? Was it in the muscularis?
Yeah, it's usually, what I've seen it's been in the submucosa or the tunica muscularis. It does look like we have a paper that I can look up. Let's see if I can do this and share my screen. Let's do this. Let's try this. Thank you for sharing. And then I will go through and say, let's share this. Share screen. What's the paper? This one. Okay, so you guys might see somebody just put on the chat. It's 1997, so an older paper, but it might be a good place to start to talk about the fact that it can happen, and it might happen in just older dogs. I don't know. I mean, it seems like it's uncommon anyway. And
That's awesome. I didn't find this paper in my search, so that's nice to know there's at least something out there.
And I mean, honestly, Julie, the other thing you can do for that case, if you guys are interested, Dr. Hokamp and I have submitted cases to, and also Dr. Martinez as well. We've submitted 2 cases to the protein core, the proteomics core here at OSU, and we basically just give them the paraffin block, and then they tell us what amyloid it is. It's really easy to do. I mean, we have to do it after COVID stuff. We can't do it during COVID because they're not allowed to do anything. Do you want me to move on to my GWiz cases, or yay, nay? Okay, I'm gonna take silence as acquiescence. So,
yes.
Okay, this one, I have to admit, both cases are, actually I wanna do the other one first. They are consults. They were originally diagnosed at Antec, and so I don't have a lot of history for them. And I'm trying to get the clinician to provide a little bit more history, but then, so basically, I think now mostly Antec and IDEX, when they get kidney biopsies, do have a blurb. They have a boilerplate where they say that, if the clinician wants more additional diagnostics, they can submit to the diagnostic service. And so it's very strange because this is, I basically got a paraffin block from this case that had pretty much an entire kidney in it. So I don't know if they did an entire nephrectomy. I did check with the clinician. The dog is still alive. So maybe they did an entire nephrectomy, or they just took a really, really, really large wedge. I'm not sure. But this case, and that's the image that Antec took, but I'll show you a few more images of what we had. It sounds like the clinical information was vomiting, diarrhea, and weight loss. I'm assuming the dog had some degree of proteinuria, and that's why they did a renal biopsy at the same time. But again, the clinical history is limited. I guess I should tell you it's a male Shih Tzu that's 8 years old, and his name is Poby. That's such a cute name. Okay. So then they commented that maybe they should send it to us. So the clinician asked us to do it. So I'll just open all the pictures. Okay, so this is me. Hopefully you guys are seeing a glomerulus. Yes? Are you seeing a glomerulus?
Nope.
No.
Okay, I think I have to change my screen. Share photos. Let's share this. Okay, thank you. Okay, so
Yeah.
you're seeing glomerulus. Okay, so this is again almost like an entire cross section of a kidney, and the glomeruli were uniformly this severely affected. So it was a diffuse process. I hope everybody can see all of the nuclei. There are numerous nuclei per segment in each lobule or each segment of the tuft. And most of the time we want 2 to maybe 3 mesangial cells at the base of a glomerular capillary loop. And we range from 6 in this particular segment to maybe 10 in that particular segment. And this, I can't even count, maybe 50. So it's a hypercellular glomerulus. There is a lot of extra eosinophilic material. The capillary loops themselves, which might be easier to see on the PAS. Let me go to the PAS. Hold on. Don't look. Okay, keep going, keep going. Okay, so the capillary loops, this is actually a great one. So here, if you guys are seeing the PAS, you can see the glomerular basement membrane. It's going all the way around here. This area should be mesangium, and it's all, it's paler pink than normal. This would be the normal mesangium pinkness, and instead this is paler pink, so we call that mesangiolisis because the mesangium themselves has dissolved. I have no clue what these cells are. I think they might be endothelial cells. I can't verify that. They also could be infiltrating leukocytes. They could be, I guess, maybe macrophages. It's strange because I feel like they look like podocyte nuclei, but they're clearly within the capillary loop, so they cannot be podocyte nuclei. It's very strange. And then the other thing is that there's this like extracellular matrix that really has very little cells in here. And so this, you know, we have matrix that's being deposited without a lot of cellularity. One of the other comments I had is that there's a lot of nuclear debris. So you can see this might be a neutrophil nucleus that's kind of torn apart, and then you have these little tiny blebs of previous nuclei that are hanging out. So there's a lot of kerarectic and nuclear debris. This is the silver stain, and again, the mesangiolisis. So here would be where a normal glomerular basement membrane capillary wall should be, and instead of having really good black mesangial matrix, instead of having that normal black mesangial matrix, you have nothing because it's completely dissolved. Another thing, oops, sorry, go to this way, sorry. I wanted to go back. Okay, okay. Here is another region of mesangiolisis, and so that's there. The other thing is I feel like, or the comment that I made to the veterinarian is that in some of the areas, and this was repeated in multiple glomeruli, I only have a few pictures, but in some of the areas where we had that extracellular matrix deposition without a lot of nuclei, it's not really consistent with collagen because collagen should be that black, and this is, you know, extra material. And I don't know what that extra material is. I don't know whether there's fibrillar material being deposited here. It's very possible that this patient has 2 different diseases. He has something that's making his capillaries really inflamed, and then he also has mesangial fibril deposition. It's very possible. Here's another area that doesn't have good take-up. And here, I think you can actually see all of these areas should be dark black, similar to this, and instead they're that pale gray. So I do think this patient actually is suffering from 2 different diseases. I don't have a Congo red for this case yet. I'm gonna have to get the block back in order to do the Congo red. But I will have a Congo red to see if there's amyloid in those glomeruli in addition. Even if the Congo red is negative, I still think there's additional material hanging out in this mesangium that isn't normal mesangial matrix. So this mesangiolisis, this endothelial damage, this hypercellularity, here's a red blood cell cast within the medulla. So it's basically bleeding from its glomeruli. And it even has what we call crescents. So this would be an area where the capillaries have like burst open, and now we have this fibrin coagulum within Bowman space. So it's a very crescentic damaged lesion because of the degree of capillary wall damage. So I asked so this came as a paraffin block as a consult. I don't have tissue that came in my EM fixative, and I didn't have tissue in formalin. I did ask if they wanted to do electron microscopy to see if there truly are immune complexes. I strongly think that there are. I strongly favor this as being an immune complex process. But I asked if they wanted to. They don't really want to spend the extra money. They just know it's really bad. And so, and even for me to do it just for my own academic interest, the quality of paraffin embedded tissue that then goes for EM it's okay. Like I can make a diagnosis, I can see immune deposits, but it's never really publishable. Like it's not publication quality. So even though this might be a gee whiz of having two different diseases of like maybe fibrillary or amyloid deposition, as well as an immune complex or hypercellularity process, it's really not something I could even write up as a case report just because of that. So I'm not sure what I want to do. This case just came through yesterday. But I did tell the clinician, you know, based on how much inflammation I'm seeing in the glomeruli, that, you know, if the dog is still alive, they should try, I mean, trying immunosuppression is reasonable, but that I don't know how it's going to respond given how much matrix has already been deposited in these glomeruli. Any questions or comments about that case? Anything? Okay. I can show one more gee whiz, which is a little bit different. Let's see. Go to my other case. Again, this was a consult case. I don't know if I'm going to be asked to do EM for this case or not. So I can tell you that, I know you guys haven't seen my screen, so share this. This dog is a Chihuahua. He's 5 years old, and diagnosed with kidney disease during the spay. They did a biopsy. He's on benazepril, kidney diet, and it sounds like they, I think from the email from the clinician, this dog was azotemic. They were working it up more as an AKI patient, but in and then work up with the evaluation of AKI, they determined that the dog had pretty significant proteinuria at the same time. So let's see, one more time to share. Stop sharing. New share. Let's see. I think this is correct, but let me just double check. Nope, it is, but the PS. All right, so I apologize. This is an H&E. I send it back to the lab because really there's no E in there. It's just mostly H. So they're restaining it for me. So the H&Es aren't great, but they're getting restained. But the reason I am showing this case is that, okay, if we go to the silver stain, let's go to the PS first. Hold on. Close your eyes. Okay. So we go to the PAS stain. This dog had a couple core biopsies. And they had a total, I think, of like 12 or 13 glomeruli or something like that. It has a couple of different things going on. It has a little bit of hypercellularity. It has a little bit of pycnotic karyorectic debris. This bright fuchsia stuff, this stuff here on PAS is going to be plasma that's being pushed into a capillary. So we have some hyalinosis. We have this little glob of stuff that I think is in Bowman's space. It's not actually in the glomerulus, but it's this bright protein-rich material. And let's go to this one. So the other thing is that we have, again, these kind of dense, thickened capillary walls. But if you look on the Bowman space side, there's a lot of podocytes out here. There are quite a few podocytes that have prominent nuclei. If you go to the trichrome, which is also very helpful, you can see here's our capillary loop. And then outside in Bowman space, we have all these red dit dots that are hanging out inside the podocyte cytoplasm. So those are protein reabsorption droplets. Here's another example up here. This podocyte has a whole bunch of protein reabsorption droplets. I don't know if these little blobs here are podocytes or if they're maybe immune complexes. It's very difficult to tell. Here's another glomerulus that has a lot of protein reabsorption droplets in its podocytes. They vary from small to quite large. And a third one, and I think you guys can clearly see now, here's all of these cells that are on the outside of the capillaries that are just chock full of protein droplets, and their nuclei look angry. They're just so large. They have prominent nuclei and nucleoli, and then they just have this huge abundance of protein droplets. And then you can see this glomerular tuft is actually kind of compressed and basically squished because all the podocytes are angry. This podocyte here actually has a really large vacuole that we can see from outer space. It's huge. These are more protein droplets. So the podocytes are severely injured. This is that exact same glomerulus with the podocytes that I was showing last. And you can see that the capillaries, they're so compressed and there's really no room for that capillary to be open and patent. It's reminiscent of collapsing FSGS that we can see in humans, a focal segmental glomerulosclerosis lesion. I don't know if that's the correct diagnosis for this, but it is one of the more, it would make me concerned if I saw this in a human for that type of disease. So I said to her, I told this clinician that we could do EM. I might find immune complexes if I'm looking at capillaries and segments of the top that look like this, because they do have a thickened wall. They have kind of expanded mesangium by collagen. So there might be immune complex deposition here, but there's going to be a lot of podocyte injury, and these podocytes are going to be very large and taking up a lot of bone space. So I'm not sure if she's going to opt for EM. I think that this dog is from a rescue organization, so they may not have a lot of money. But I said, you know, based on the segments that look like they could have immune complexes, you know, maybe if this dog isn't responding to anything, like trying immunosuppression is worthwhile. I just don't know how this dog is going to do given the degree of how injured his podocytes are. So you might be able to get rid of the immune complexes or stop more from being deposited with immunosuppressive therapy. But those podocytes, a lot of them are going to die. And so then you're going to have really bad segmental scarring afterwards. So a couple of GWAS lesions. For those of you guys who get my reports when I send them out, you guys will be able to follow these pictures as well. And I don't know for either of these cases what's going to happen. So that's kind of sad ending to the story. Do you guys have any questions? Was this a lot of pathology that made your head explode?
No, it was very educational. Thank you.
If there is any additional follow-up or questions, thank you very much for looking in this GI. Never too much pathology. Thanks, Dr. Martinez. If you guys, thank you for the additional piece of information for the GI amyloidosis. It might be something we could do a pretty easy search in our database to see how many times we've diagnosed it in dogs. I think that hopefully at some point we can get the information out so that we can tell clinicians that sometimes amyloid cases can do quite well. And I think that what we'll see is that even cases that have moderate or maybe even severe amyloid will actually be able to live for a longer time than we would normally expect. So I wouldn't take anything for my, I wouldn't take anything from the concept of the severity on the glomerular tuft. It's really honestly, in my opinion, and this is the pathology opinion, and I think I've talked about it with JD before too, it's, you know, what the owner wants to go through. So if the owner wants to deal with a dog that might be having effusions, that's going to be a better, you know, they're going to live longer no matter how bad the amyloid was to begin with. If the dog is able to maintain albumin or get albumin supplements and be able, or, you know, be able to maintain a normal albumin, then maybe it's going to do better as opposed to the ones that are hypoalbuminemic. So, okay, well, I hope everybody at least enjoyed, and let us know if there's other cases. I'll send out another invite in May. It's usually the 4th Thursday at this time frame. And this will also be uploaded to, we have a box folder that has a lot of recordings. If you guys want the recordings, you're more than welcome to ask, and I can give you an invitation to the box folder. Okay, well, I think I'm going to end here if that's okay with you guys. Okay.
Thank you.
Thank you so much, Rachel.